Good morning, Doc. So for OB Module 2, next slide, please. The case is a 28-year-old Gravida 3 para 11011, 32 weeks age of gestation, was brought to the labor room for profuse vaginal bleeding. Patient claimed it was not associated with hypogastric pain. Last sexual intercourse was 1 week ago. She had no fever, dysuria, changes in urination, or bowel movement. She had no history of abdominal manipulation. She is compliant with her prenatal schedule and had normal vital signs during those schedules. She had no previous ultrasounds nor labs done. On physical exam, patient was pale with a blood pressure of 90/60, heart rate of 120, respiratory rate of 30s, temperature of 37.1 degrees Celsius. An abdominal exam fundic height is 30 cm, soft, no guarding or rebound tenderness, and the uterus is non-tender. Fetal heart tones are in the 140s with good variability. On speculum exam, noted open cervix with minimal active bleeding. Next slide, please. So number one, what are the salient features? So first is the age of the mother. She is 28 years old. She is a gravida 3 para 11011, which means she has one term infant, one previous ectopic pregnancy or abortion, and one living child. She is at 32 weeks age of gestation, came in due to profuse vaginal bleeding and is not associated with hypogastric pain. She also has no fever, dysuria, changes in urination or bowel movement. She has no history of abdominal manipulation, had had sexual intercourse 1 week ago, and her prenatal visits were normal, although no ultrasound or labs were done. On physical exam, she is pale, um, hypotensive, tachycardic, and tachypneic, but her temperature is normal at 37.1 degrees Celsius. On abdominal exam, fundic height is also normal at 30 centimeters, soft, no guarding or rebound tenderness. Also noted non-tender uterus with fetal heart tones at 140s with good variability, and on speculum exam, noted open cervix with minimal active bleeding. Next slide, please. So number two, what are the causes of third trimester bleeding? Give the two differential diagnoses and give their differentiating characteristics. So on this slide, we listed some of the causes of third trimester bleeding, and we will be giving the two differential diagnoses on the next slide. So first, we have placental abruption, which is the most common cause of serious vaginal bleeding, and it is referred to as the separation of the placenta from the uterine wall before delivery. Another serious condition is placenta previa, wherein placental implantation overlies or is within 2 centimeters of the internal cervical os. Third is vasa previa, which is the filamentous insertion of the umbilical cord into the membranes in the lower uterine segment, resulting in the presence of fetal vessels between the cervix and presenting part. Other causes also include preterm labor, morbidly adherent placenta, bloody show, which usually accompanies cervical dilatation during normal labor. Um, uh, Pregnant women also experience spotting or minor bleeding after sexual intercourse or digital vaginal examination. And other underlying causes include cervicitis, cervical ectropion, cervical polyps, and cervical cancer. So based on our PE and history, next slide please, we included two differential diagnoses, which um, placenta previa and placental abruption.
Good morning, everyone. For the differential diagnosis, as mentioned, we have placenta previa and abruption of placenta. So, for placenta previa, for the bleeding, we have plain is vaginal bleeding. It's usually bright red. There is no abdominal pain, rather. The uterus is normal in tone and non-tender. For labor, patient is rarely in labor, and for engagement, presenting part is unengaged. For fetal parts, it is palpable abdominally, and for fetal heart tones, it is auscultated.
So for abruptia placenta, we have the following characteristics. Bleeding. Bleeding is accompanied by pain, and it is usually in color dark red. For abdominal pain, it is common among women. Uterus is characterized with local uterine tenderness and hypertonic or tetanic or woody uterus. Patient usually in labor and engagement is presenting part is often engaged. Fetal parts difficult to palpate abdominally, and fetal heart tones is usually auscultated with difficulty. Important signs and symptoms of placental abruption can also vary. In some women, external bleeding can be profuse, yet placental separation may not be so extensive as to compromise the fetus. In others, there may be no external bleeding, but the placenta is sufficiently sheared off that the fetus is dead. A concealed abruption. In one unusual case, a multiparous woman cared for at Parkland Hospital presented with a nosebleed, and she had no abdominal or uterine pain, tenderness, or vaginal bleeding. And her fetus was dead, however, and her blood did not clot. So it sometimes it varies. Yeah.
So for LO3, how will you manage the case from the time of admission, and what is your plan of management, diagnostic and therapeutic, and explain. So the initial management of significant bleeding in late pregnancy is similar regardless of the etiology. So visual estimates of blood loss should be recorded but may be inaccurate or fail to account for concealed hemorrhage. So since our patient is hypotensive, tachycardic, tachypneic, and some presence of maternal symptoms of hemodynamic instability, in which these are ominous indicators in which it reflects to our case. And women with these signs, um, they are required immediate intravenous access, fluid resuscitation, and the availability of blood products. And the baseline laboratory tests, which include hematocrit, platelet count, fibrinogen level, coagulation studies, blood type, and antibody screen. And women who are Rh negative uh, should receive a ROGAM, and a Clay-Hauer-Betke test should be performed to determine the appropriate dose. And continuous fetal monitoring is recommended, and decelerations or loss of variability may resolve with adequate maternal resuscitation. And however, a persistently non-reassuring fetal heart rate tracing may require urgent cesarean delivery before the etiology of the hemorrhage is established. Next slide, please.
So for therapeutic plan of management, because most of neonatal morbidity and mortality associated with placenta previa results from complications of prematurity, the main therapeutic strategy is to prolong pregnancy until fetal lung maturity is achieved. So we could use tocolytic agent for the prolongation of gestation of vaginal bleeding occurs with preterm contraction. Next, we could use corticosteroids should be administered to women who have bleeding from placenta previa at 24 to 34 weeks estimated gestation. For outpatient management, it is appropriate for selected patients who do not have active bleeding and who can rapidly assess a hospital with operative labor and delivery services. So because of placenta previa may resolve close to term, it is recommended that no decision on mode of delivery be made until after ultrasonography at 36 weeks.
So for LO number four, make an algorithm on the management of third trimester bleeding. So um, so we can classify third trimester bleeding as either painful or painless vaginal bleeding. So in all of these cases, we can since management is individualized, so we can administer IV fluids and blood products um, based on the status of the patient. So these are the four most common causes of your third trimester bleeding. So for the painless vaginal bleeding, you have your placenta previa and your vasa previa. And for your painful vaginal bleeding, you have your placental abruption and your uterine rupture. So since the definitions of these conditions were already explained in LO number two, so I'll just skip to the management. So for placenta previa, if there is already maternal or fetal demise, then an emergency cesarean delivery would be done. But however, if the mother and fetus are stable, and the fetus is less than 36 weeks, it should be a close observation with pelvic rest. However, if the fetus is already more than 37 weeks and both the mother and the fetus are stable, then we can already schedule for cesarean delivery. So for vasa previa, if the fetus is less than 36 weeks, then we should administer antenatal corticosteroids at 20 to 32 weeks, age of gestation, and scheduled cesarean delivery at 34 to 37 weeks AOG. And if the fetus is already more than 37 weeks, same with the placenta previa, we should schedule cesarean delivery. So for the painful vaginal bleeding, for placental abruption, so usually this is a more severe case, and if not treated immediately, can result into death of the fetus. So if the fetus is dead or unable to live outside the uterus due to non-viability, vaginal delivery is preferred than with application of uterotonics post-surgery to prevent further bleeding. So, however, if the fetus is compromised but can live outside the uterus, then an emergency cesarean delivery will be done. Then, if the fetus is less than 36 weeks age of gestation and the fetus is stable, then a tocolytic therapy with magnesium sulfate would be preferred than delivery at 37 weeks. Then for your uterine rupture, so this should be managed by an immediate delivery by laparotomy. So since there is no more um, uterus, so laparotomy would be the preferred technique. So after the procedure, if the mother is stable, then the mother also has wishes to undergo another pregnancy, then a uterine repair would be preferred. However, if the patient is unstable after the laparotomy and the mother does not wish anymore to have further pregnancies, then an hysterectomy should be advised. So I think that would be all for LO number four. So based on our case, we had the primary impression of G3P1 1011 pregnancy uterine 32 weeks POG by LMP, possible placenta previa.
Doc, that would be all, Doc. Thank you, Doc.
Can you go back to the case of the patient? Go back to your management, last slide. So for this patient, how will you manage your case?
So based on this algorithm, doc, since the fetus is stable, since there is normal fetal heart tones, and the mother is um slight has slightly abnormal vital signs, I think we can still do the close observation with pelvic rest, doc.
What do you mean by slightly normal? There's no such thing as slightly normal. It's either normal or abnormal.
The vital signs are abnormal, doc, but since there is still compensation based on the um there's still compensation, I think the patient is still stable, hemodynamically stable.
Yes, the patient has active bleeding on admission.
Minimal active bleeding, doc.
So what was your impression on this case?
Um, placenta previa, doc.
Can you go back again to the case? The clinical case of the patient. Can you go back to the first slide?
That's the only case given, doc. This paragraph.
Your patient is already hemodynamically unstable with a heart rate of 120s and a respiratory rate of 30s. That's not normal anymore. So how will you manage this patient again? Observe. You will just observe the patient.
We'll do the ano na doc, cesarean delivery.
And then what are you going to prepare before doing a cesarean section? What are the labs that you should request and what are the things that you should prepare before the surgery?
We can give doc IV and then fluid resuscitation doc and the availability of blood products. And then for the laboratory workup, we can order CBC, the coagulation studies, doc, to check the fibrinogen level, blood type, and antibody screen. And if women doc who are Rh negative, uh, she should receive ROGAM, and then we can perform also Kleihauer-Betke test doc to determine the appropriate dose, sorry, and then continuous fetal monitoring is recommended also, doc.
What else?
Mm,
For the labs? Other group members?
Also include doc blood typing doc.
Already mentioned.
Um, ultrasonography, doc.
You're bringing the patient to the operating room already. your ultrasound is of no benefit anymore because you're bringing the patient to the operating room already. What are the labs that you should request prior to doing the surgery?
I think one lab that must be done, doc, would be the coagulative studies, doc, to know if there is decrease in the platelet levels or the fibrinogen levels.
Already mentioned.
Another one, doc, if the patient must undergo surgery, is the cardiopulmonary clearance.
It's a stat OR. You don't need the cardiopulmonary clearance because it's a stat of surgery. You need to request for the hepatitis B antigen, and then your patient is already hemodynamically unstable. You have to check the perfusion. Patient is already tachycardic. You should also request for the creatinine and BUN. What other procedures are you going to do prior to surgery? As what I've said, you have to monitor the perfusion status of the patient. How will you monitor the perfusion status of the patient?
Um, ABG doc.
Aside from ABG, what else?
Um, during surgery, doc, I think we can do the during surgery. I think we can do the um, central venous catheterization.
It should be done before surgery, but it's not what I'm looking for. What else? The simplest way to monitor the hydration status of your patient.
Urine output, doc.
Yes. How will you measure the urine output?
For urinary catheter, doc,
By
Bernard
inserting
valve.
FBC. What else?
We can also take the O2 saturation, doc.
It's already included in your vital signs. What else? You insert second line because your patient is already hemodynamically unstable. If you bleed intra-op, then at least you have another line. The other line for blood transfusion, the other line for fluid resuscitation. That's why you need to insert FBC to monitor the hydration status of the patient. Post-operatively, how will you manage the patient?
So since it is all CS, doc,
What are
for
your advices for the patient?
pain management, doc, we can give analgesia, doc.
It's not only analgesia, what else?
Since the patient underwent cesarean delivery, doc, we can educate the patient on how to do the wound care.
What else?
You can also monitor the vital signs during the first few hours after surgery, doc.
What else? Before you discharge the patient, what will be your advice for the patient? One should be family planning. You have to counsel the patient for family planning because she just underwent cesarean section. And you should also inform the patient that she cannot get pregnant for the next 2 years to give time for that incision, the cesarean incision to heal. That's why you have to give family planning advice to the patient on what family planning she will use because she cannot get pregnant for the next 2 years. And if she gets pregnant after 2 years, you will advise her to seek prenatal consult at a tertiary institution, not at a lying-in clinic, because a lying-in clinic cannot deliver a cesarean section. They cannot do cesarean section. So they should have their prenatal consults at a tertiary institution, attended by an obstetrician and not by a midwife. Do you have any questions or clarifications?
Doc, may nalay confusion, Doc, sa case, Doc, ba kay the patient was brought to the labor room for profuse vaginal bleeding, and then pag sa speculum exam, Doc, kay minimal active bleeding.
It can happen that the patient had profuse vaginal bleeding, but when she arrived at the labor room, she's not actively bleeding already. It can happen.
So, ma-conclude gihapon, Doc, na placenta previa.
Actually, your physical examination findings is lacking. There's only noted open cervix with minimal active bleeding. There's no mention of presence of placental tissues. If there's presence of placental tissues, then that's the time you can also conclude that it's a placenta previa. And you can also base it on the history of the patient. Patient is not hypertensive, no history of trauma, and then patient is profusely bleeding.
Okay, Doc, thank you.
Other questions?
I think none so far, Doc. Uh, but Doc, nami question Doc ba Doc about to sa katong last meeting bitaw na to nga wala na hitabo Doc. Kanusa na to ma kuan Doc katong for EINC and episography Doc.
We will have it together with the pap smear skills lab because we have no class tomorrow, right? Because it's a holiday.
Yes, Doc. Thank you, Doc.
So you will divide among your group. You will assign who will perform the EINC, who will perform the episho, and who will perform the pap smear.
Noted, Doc. Thank you, Doc.
Any more else? We have no class on Thursday because you have a lecturette. So I'll see you on Friday for the gynae history.
Yes, Doc.
Okay, thank you everyone.
Thank you,
Thank you, Doc.
Doc.
Goodbye, Doc. God bless,
Thank
Doc.
you, Doc.